Okay. Hey, what's good, everyone? Um, I heard that a lot of people are having problems with understanding ultrasound, so I'm just here to do my part and make things more understandable. I think the problem is that you guys didn't get a chance to build a solid foundation with ultrasound, and once you just know the basics of how ultrasound works, the basic foundation, I think you're gonna have more confidence when looking at an ultrasound image, and you're gonna be able to delineate and just understand ultrasound images. Just think of X-rays. You guys built confidence looking at X-rays over the last 3 units, and the same thing is gonna be with ultrasound. And I'm gonna teach you like how to take what I'm giving you and apply it. I'm not just gonna give you like random information, facts. By the end of this, my goal is to have you guys be comfortable with ultrasound to the point where you can apply it almost to the extent that I know this stuff. And I think I can do it. I think I can get you there like by how I'm gonna come across. All right. And then Kenny. Kenny's here as well. Stuyvesant graduate, Kenny Chen, also known in these streets as Kenny G. So Kenny's gonna he's just gonna be here if I'm saying something that's confusing, or if I'm using jargon like radiology jargon that is not clear to a regular MS1 student, or if I'm going over topics too quickly that requires more elaboration. Kenny's gonna speak on that. He's gonna stop me. All right, Kenny,
I'm
you wanna
excited.
say something?
You're making me feel so good, Shrek. Let's
Yo,
do this.
you're the shit, Kenny. Oh, I done already cursed. All right, let's do this. All right, we got this. Check it. Okay, so all right, Kenny, do you see my PowerPoint up? Kenny,
hmm Yes.
it's up.
hmm
All right,
I see a person.
nice. That's what I want you to
hmm
see. Where's the present button?
It's right there.
Aha, bam.
Yeah.
Okay, everything looks good, Kenny.
I hope so. Looks like a human.
Okay, so like I was saying, basic foundation is everything. Once you understand the basic foundations, basic principles, you you're gonna be able to figure out ultrasound. Like your strength at looking at doing tough things come from knowing the basics. So first of all, just know the planes real well. Whenever these three planes are mentioned, you should just know it like the back of your hand. Like coronal cuts it anterior posterior, sagittal cuts it to right to left, axial cuts it top to bottom or bottom to top, right? Now, one thing I would like to mention is that in ultrasound, they like to, not they like to, but this is a convention, they call the sagittal and coronal plane the longitudinal plane, and they call the transverse plane or the axial plane the short axis plane. And it makes sense.
Wait, they call the coronal and the toe the longitudinal?
Yeah, so check
Holy
this out.
shit.
This is why.
Okay.
Because if you look at it, the coronal and the sagittal, they're both along, both planes are along the long length of the body, right?
hmm
But the axial is along the width, it's along the short width of the body. So that's why they call the transverse plane the short axis. But both
hmm
longitudinal and coronal, they're both along the length of the body. So they call both of them longitudinal planes.
All right.
And then you'll see, like in ultrasound of a gallbladder, they'll say this is a longitudinal view of the gallbladder. So they're
hmm
basically saying they took a picture of the gallbladder along its length. And you'll see what I mean. But for now, just know that they call both the sagittal and the coronal plane longitudinal planes, as you can
hmm
see, as it's marked here too.
Hmm. Gotcha.
Gotcha. Okay, next. Now, just know these planes. I know, like, with CTs and MRIs, it's easy to understand the planes, right? But in ultrasound, people always trip up, like, all right, if this is a sagittal plane, where did they put the transducer? How did they do this, right? So this
Hmm.
clears that up. So this is a sagittal plane. They're getting sagittal images, and the transducer is placed on the anterior side, on the stomach, on the tummy, whatever helps you remember. And then the depth of the transducer, where it fans out, that's going to be the posterior side. Another thing I would like to mention, very important, another convention is that in both longitudinal planes, in sagittal plane and coronal plane, they put that transducer marker towards the head superiorly. As you can see, that little red dot right here.
Hmm.
You can see
Yeah.
my cursor, right, Kenny?
Yeah.
Okay, so that red dot in both sagittal and coronal planes, they put the red dot towards the head.
Hmm.
So this is a sagittal plane. This is how they're going to acquire sagittal images. They're going to place it on the anterior portion of the body, and they're going to go right to left, as you can see by these red lines. That's the way they're going to move. They're not going to move up and down at this point once they have the structure. So these are how the slices are going to be acquired in sagittal planes. So once again, the transducer is going to be placed on the anterior side. That's where you're going to see the narrow end of the cone, and the wide end of the cone is going to be the posterior side. Red dot mark superior. What's left is inferior.
Yeah.
Next, you have the coronal plane. Coronal plane divides the body into anterior and posterior cuts. And once again, like I said, the transducer marker in both longitudinal planes are going to be placed towards the head. And this way, in the coronal plane, it cuts the body in anterior posterior, as you can see by the red lines. In this case, the transducer is placed on either lateral side, and the narrow end of the cone is going to be your lateral side, and the wide end of the cone is going to be your medial side. And once again, transducer marker marks superior, what's left is inferior. Lastly, we have what's left is the transverse or axial plane, and in this case, the transducer marker is placed toward the patient's right, and it's the transducer is placed on the anterior portion of the body. So the narrow end of the cone is your anterior side, wide end of the cone is the posterior side. Transducer marker, like I said, marks the right side, and what's left is the left side or left lateral. So far, so good, Kenny?
Yep.
Nice.
Good.
Cool. So that transducer marker, it's gonna give you navigational landmarks into where you're at once you figure it out. If it's a longitudinal cut or a transverse cut, once you have that figured out, you can use the transducer marker to figure out the rest, and then you'll be able to figure out how the anatomy is presented on the image. Next, this is just information to know that transducer marker comes in handy in a lot of cases. So if you can't find IV, a lot of times they use ultrasound to get an IV axis, and then they put the transducer along the length of the vein, and then they use a needle. They guide the needle in where the transducer marker is, and it shows up on the screen. So they use that to do a lot of interventional studies. Next, just a quick review of ultrasound terms. You have we'll start with isoechoic. Isoechoic is homogeneous, and it has the same signal as surrounding tissue. Hyperechoic has very strong signal. Hypoechoic has relatively less signal. Anechoic has no signal at all. Next. Okay, so this picture pretty much is going to define everything about ultrasound physics, everything that you need to know in your shoes for now with ultrasound physics. I'm just going to tell you right now, okay? So just bear with me. It's not rocket science. If you don't get it the first time, just play over my recording like second time, third time. You're gonna get it. And then Kenny, if I get confusing, just let me know.
All right.
So these transducers, right? They put out sound waves, and different transducers have different strengths. So when these sound waves are put out, different things happen to the wave, right? And as you can see in this picture, some of the wave is gonna scatter. That's lost. That's just lost. We accept it as facts. Then some of it's gonna reflect it back. That's what's gonna give us our signal, the reflected back signal. The reflected back sound waves, that's gonna be our signals that the transducer uses. Important point to make, the transducer puts out sound signals or sound waves, it reflects, it comes back, and it also records the sound waves that are coming back. So the transducer is not only sending out signals, it's also receiving the signals. Like whereas in X-ray, you have the X-ray beam and there's like a cassette on the other side. It's two different things. But with ultrasound, the transducer does both. And then, so as I was saying, your sound waves, Kenny, Kenny, are you there? Hello?
All right.
Hello?
Mm-hmm.
When did I lose you?
We're gonna talk about scattering.
Okay. I'm just
Yeah.
gonna, okay, I'm still recording, so that's good. It's okay, we can edit this out.
It's cool. Yeah.
Okay. So, once again, okay, so sound waves get put out, and the transducer, it's not only it sends out sound signals, it also receives it. It does both. So when you put out sound waves, some of it gets scattered and lost. That's never coming back. We just accept that. Some of it reflects back. That's what we use to create the image. Some of it's refracted. What's refracted is basically it's just physics. When something goes from one density to another density, it bends. Kind of like when light goes from water to air, it'll bend. So that's basically what refracted. The sound wave hits something and it just goes in another direction. That's also lost. Now, what really comes to use on the image is the reflected wave and the transmitted wave. Okay? So the ultrasound puts out a signal, whatever reflects back, it records it, right? And then some of it penetrates through and hits the next structure, and then it bounces back, it records that. So the ultrasound transducer uses two things, okay? It uses the bounced back signal, the reflected signal of the structure, and it it uses how long it takes for that signal to bounce back. So if it takes a long time for that signal to bounce back, the transducer knows that okay, it's coming from a deeper area. So I'm putting out a sound wave, bouncing, coming back real quick, and some of it's transmitting, right? So whatever's coming back, it's a certain amount of signal, and it came back really quick. So the transducer is like, okay, it's superficial. And then whatever didn't get absorbed, some of it got absorbed, some of it got refracted, some of it got scattered, some of it transmitted, right? So this thing right now, whatever's left, it goes and hits the next structure, and same thing happens. Some of it refracts, some of it gets absorbed, some of it scatters, but most importantly, some of it gets reflects back, right? And it comes back to the transducer. And the transducer's like, oh, okay, it took it a little bit longer to come back, so this area must be a little bit deeper. And it also recognizes, okay, how much strength does this sound wave have that's coming back? And then it gives a light intensity based on that. So now the important point is that at some point, as it's going through structures one after another, the amount of transmitted waves or the strength of transmitted waves is eventually, you see how it's like faint? It's going to get fainter and fainter as it gets deeper. So that's your limitation. At whatever point, all of your sound wave or the all of your frequency is used up, by absorption, refraction, scatter, and reflection. At whatever point all that's used up, that's your as deepest you can go with an ultrasound transducer. And different transducer has different energy in their waves, so it can go deeper depending on different transducers. So what my important point is that it's the same wave that's going through these different structures. And at some point, that wave loses all of its energy by going through different structures, by being transmitted, by absorbed, by refracted. Does that make sense, Kenny? Am I good?
Yep. I think you got the point.
Okay. All right. So next, now those points that I just explained to you, it's going to come into practice. So it's really going to clear up right now. And so with ultrasound, there's different artifacts. I'm only going to mention artifacts that pertain to us, into what we're learning, and what has come up. What has come up in our studies so far, what pertains to you. So first, acoustic shadowing. I know this has come up, especially with gallstones. You've heard it, right? So now what I was talking about earlier is going to come into play. So the transducer is putting out a signal, right? And look what's happening, right? It's hitting something very dense. So once it hits something very, very dense, and I'm talking about something like bone, gallstone, what else? Connective tissue, something very dense, right? Nothing is going to get penetrated past that because it's so dense. So it's either going to get reflected, it's going to get absorbed, refracted, but nothing is going to transmit through. It's not going to have this faint yellow portion, okay, that transmits through. Most of it is either going to be absorbed because it's so dense, and it's going to be reflected back, right? So because of that, our signal's reflected back, nothing gets penetrated. So how are we going to get any information about what's past this tissue if none of that sound wave penetrated past the structure? And hence the acoustic shadowing, because none of the sound wave is penetrating past that dense area. In this case, the rib. None of it's penetrating past the rib. So obviously, we don't have any way to get signal past that because all of it's either absorbed or reflected back. But on this side, it's going through the tissue, it's being reflected and transmitted and reflected again. So we just keep getting signal as long as that wave has strength to keep going. How am I doing, Kenny?
Right? Not bad.
Good? You understanding it?
Why is... Can I get control of your screen?
Here, I'll give you control. Bam. Go ahead.
Just wondering what's this? What's this? Is that the rib? I
Click
don't know.
it.
Can you see me moving your...
Click the screen. Then I think you get. Okay, now I
there
can.
we go. Okay. Is that the rib? Or is the rib like going this way?
The rib is gonna be, let's see. So in this case, I believe the rib is this right here, and I think this is like a, let's see, it's like in plane with the rib. You get what I'm saying? Like it would be a sagittal cut of the rib.
Okay.
Actually, it's in line with the rib. So the whole transducer, the entire length of it, is placed on top of the rib.
It's placed on
And
top of the rib.
I think this area you're getting transmission because ribs are short, right? There's spaces between the ribs.
Mm-hmm.
So this right here, I believe, is the rib. And inside of it, I think it's just you're not getting signal inside of it because it's but
Are you
it's
moving the
just,
mouse? I can't see the mouse move right now. Oh, there we go. Now I see it.
yeah. Go ahead.
Show me again.
So what I'm saying is like the rib, there's spaces between the ribs, right? So we're just getting acoustic shadowing where the ribs are. So then these areas, this the space, this the intercostal space.
Okay. Mm-hmm.
Good.
Mm-hmm.
But you get why we're getting the acoustic shadowing, right?
Yeah. Gotcha.
Okay. Now the opposite is an acoustic enhancement. That's the flip side of that coin. So in this case, we're sending out a signal, right here. So this is like regular tissue. The left,
Mm-hmm.
the diagram on the left. Can you see my cursor?
Yeah.
Okay. So in this case, we're sending out a signal. The signal reflects back. We get some information. Some of it gets transmitted through. It reflects back. We get some signal, some information. It transmits through. But in fluid, right? So this is like, let's say, skin. Okay. So we send out a signal. It bounces off the skin, reflects back off the skin, if we were to use accurate terms, and it gives us a signal. But now fluid is the least dense thing there is. It's not going to absorb much and it's not going to reflect much. So what happens is in fluid, it just goes straight through. Nothing gets absorbed, or very little gets absorbed, very little gets reflected back. So it shows up dark. But here's the caveat. So nothing got absorbed in this area, right? So the next structure it hits, something gets absorbed back, something gets reflected back. But what gets reflected back is a little bit extra because nothing got used in this cavity here. So whatever didn't get used here built up and reflected off the next structure. So the transducer is like, oh wow, I'm getting a whole bunch of amplitude from this structure past this fluid filled structure or this cyst or whatever. Past this cyst, I'm getting a lot of amplitude back. And it's like, okay, that structure must be really dense. So I'm going to give it a lot of signal, but it's not necessarily dense. What happened is the signal just built up. Nothing was absorbed. Nothing was reflected. So all that extra signal now hits the next thing in line past the cyst and gets reflected back. It's like a little bit, nothing was spent. Nothing was absorbed. So that this transmitted wave, right, was a
Mm-hmm.
great amount because nothing was lost. It's like some of it was reflective off the skin, but it stayed very strong through the fluid because nothing was reflected or absorbed. So the next structure it hits, it's gonna reflect back a lot of amplitude.
Right.
So now that's why anything past cyst or fluid filled structures such as bladder, a large vessel like the aorta, even sometimes the gallbladder if it's filled with just bile, regular fluid, past it, distal to it, deeper to it, you're going to get a strong acoustic enhancement because of that reason. How was that?
Good.
Okay. All right, now we're just